and national faculty, Professor Ajay Singh and Dr. Ritesh Runu, you are welcome to be here, and also our own faculties are there. So today's subject, the CTEV, is a very controversial and most common subject. So we expect we have a very good discussion and we come out with some guideline about the management and its treatment protocol. So with these few words, I conclude my welcome speech. Thank you all.
Yes, now over to you.
So now I would request Professor Ajay Kumar Singh to deliver his keynote lecture.
So Professor Ajay
Thank you
Kumar.
very much.
Yes, sir. I am sharing your screen, sir. Please.
Yeah,
It's
please.
there? Yes, sir. Please.
Thank you. At the outset, I am really grateful to West Bengal Orthopedic Association for organizing this this pediatric orthopedic CME and asking me to join you. It is a great privilege for me. I will speak on club feet, what is new in idiopathic CTEV. Next, please. Next, please.
Yeah, I am doing it. Yes.
Yeah. Club foot is one of the commonest congenital foot problem a pediatric orthopedic person encounter in their day-to-day practice. It's a three-dimensional complex deformity involving all the joints of the foot, and every aspect of the club foot is controversial, including the lack of understanding of the functional anatomy, lack of understanding the biological response to the young tissues to injury and repair, their combined effect on the long-term outcome, how to classify deformity and how to measure the severity of the deformity, what is best method to diagnose club foot, best way to treat CTEV, and best method to evaluate the treatment outcome and the long-term outcome. Next, please. As far as the controversies and the consensus related with the etiology, there is no idiopathic club foot, which is most common type of club foot. No etiology is known to us, and no please last one, please, last one.
Yes, yes.
No specific gene is identified, and little known environmental factors affecting the occurrence of the severity of the club foot is known to us. The Spark funded largest study of the club foot in the world to investigate how club foot is passed from the parents to children. They examined the 15 Scottish schools and 113 families. They took the DNA samples and they concluded that the variation in the genetic control of the metabolism of vitamin B foliate. The pregnancy factors are there and possibly which are acting during the third mid trimester has a role in the occurrence of the club foot. They established the role of many genes, but many the Hox gene causing the club foot in the mouse. They found the positive association of the maternal smoking or the paternal smoking, and they found there is a linkage of a genome, and they are maybe affecting the development of the lower limb bud, including the muscles and the bone of the lower limb during the fetogenesis. Next, please. They found there is variation in the WNT7A and unlikely to be a cause of familial club foot. They found that the apoptotic gene analysis was done in 2007 in the patients of idiopathic club foot, and they found that the several chromosome deletion regions were associated. Last one, please. Many chromosomal deletion regions were associated with the club foot. They found that the harbor genes that determine the phenotype is responsible for the severity of the club foot. The genotyped SNPs spanning 7 apoptotic genes were identified, but no single gene has been associated with the clubfoot. These data suggest that the genetic variation in the apoptotic genes may play a role in the development of clubfoot, and this information is very important because this promises the future line of action, and maybe the gene therapy, maybe the one of the treatment for the future. Next, please. In 1964, a genetic study by Wine and Davies was done, and they found the hereditary plays a very significant role as far as the occurrence of the clubfoot is concerned. They found that the polygenic traits are inherited, the clubfoot from the parents to the children, and they found because the right foot is more involved in most of the cases. If the index patient is female, then the subsequent children being affected will be almost around 4%. But it would be 9% if the index patient is male. There is 17 times higher in the first degree relatives and 6 times more in the second degree relative. Both parents affect 30% chances in the subsequent children. So they concluded these observations suggest a hereditary role in the passing out the club food from the parents to the next generation children. Next, please. Next, please.
Yeah.
Environmental factors has also been studied to find any role of with the incidence as well as the severity of the clubfoot. And there are two studies. One is the epidemiological UK case control study was there, in which they analyzed the epidemiological features, and they find that the maternal use of folic acid supplementation in the 3 months before the pregnancy decreases the chances of idiopathic CTEV, and even if they appear, then the severity is lesser with the folic acid supplementation. The next last please. The paternal smoking we have already discussed has an increased risk, and they have found, I mean, it is now found that the lead and the arsenic is the culprit to produce these type of associations and the severity of the clubfoot. The cesarean section is significantly associated with the high risk, though there is no explanation of this, but this is our observation, and it requires more studies so that we can prove this factor. Next, please. The other is a retrospective study, which was done on more than 1 lakh of on the unselected obstetric population. In UK, antenatal diagnosed clubfoot by the ultrasound guided amniocentesis. They found that there is increase in the orthopedic foot deformities in infants whose mother underwent amniocentesis from 11 to 12 versus 15 to 16 plus minus 6 gestational weeks. So earlier the amniocentesis we are doing, the higher chances of occurring the clubfoot. This is our observation because the sampling of the former group was maximum during the foot growth. There is very we are lack of understanding as far as the functional anatomy is concerned, because the congenital dysplasia of all musculoskeletal tissues are present with the malposition of tarsal bone and the joint, including the soft tissue contracture. The main three deformities are equinus, varus, and the forefoot adduction, and associated are the cavus, clawing, and the tibial anteversion. In 2001, Dr. A.K. Jain in an Indian study, they found that the bimallular angle foot valvular angle is associated with a degree of deformity, and the cadaveric specimen also showed the association, because it this angle is gives the idea about the talar twist, and we know now that the talus is the main culprit, and its neck becomes short and goes in medial torsion. In a study in which somatosensory evoked potential was recorded from 44 children in 64 feet with a CTEV between the 2 years and 15-year deformity, 15-year deformity, which were previously treated with surgery. They find that the 18% had abnormality in the spinal level, the 50% were having the normal response, and the surgical outcome was better in those having no neurological involvement. And it is very important finding that about 18% of these patients are having spinal involvement. As far as the controversy in the classification is concerned, we are using morpho-radiological parameters, and Pirani and Demiglo system is there, and both are good, but we are using Pirani for our convenience, and both systems are having good inter-observer reliability. A new classification in 2003 based on the ultrasound evaluation was proposed by Jarikan, which depend on the mid-tarsal disarticulation. Yes, next please. Now, how to make diagnosis and quantify severity of the different deformity is a question. We can diagnose as early as 16 weeks of gestation through the fetal ultrasound, which is a reliable diagnosis. Antenatal ultrasound routinely gives an idea whether go for abdominal or transvaginal between 18 to 23 weeks, but as early as 16 weeks. Retrospective study on more than 1 lakh population give an idea about 0.01% of incidence. 22% were having complex lesions, which were including not only the clubfoot but also other neuroskeletal development. So antenatal USG is very good diagnostic tool we are having, and we must go for antenatal USG to diagnose these congenital abnormalities. Next, please.
Yes.
No. Last one. Yes. Yes. Next one. Yeah.
This one. Yeah.
The
next,
as far as the radiographs are concerned, we are not dependent on any diagnostic tool except the clinical finding to diagnose the clubfoot, because radiograph have the limitation of the bones are to get a proper position of the foot for the X-ray. But there is a role of ultrasound before the age of 6 months to diagnose the mal articulation of the tarsal bone to get an assessment of the severity of the disarticulation. But the diagnosis is not dependent on any diagnostic tool. Next, please. But there is definitely a role of radiograph, not for diagnosis, but to assess the severity of the deformity, to ascertain adequacy of the correction during the manipulation, or maybe after the surgical treatment. It gives intraoperative or during the treatment adequacy of the correction, and it confirms the maintenance of the deformity correction. This decreases the chances of last please. This decreases the chances of recurrence of the deformity. We have to understand that the stress radiograph gives more information, and if we are using X-ray, then there is now radiolucent splints are there, which should be, and under the cover of splint, we should go for X-rays. Next, please. There is 3D models, skeletal simulation has been designed for the pattern understanding of the deformities, and to know what what surgical procedure or rehabilitation protocol has to be followed. The Manak Jain in 2009 made the bio modeling of the clubfoot in babies, and this gives a detailed geometrical visualization of talus and its articulation, and gives an idea how to what type of surgery we have to do, and when we have to stop, means the correction is over. Next, please. As far as the treatment of the clubfoot is involved, the first described Indian treatment is around 1000 BC, and first written protocol is by the Hippocrates in 400 BC. It is varying from the manipulation to surgical intervention, which returned again to manipulation in the form of Pirani, and then the semi-invasive. We have, yes, next please. We have identified poor prognostic factors such as female, first child, associated congenital deformities, and rigidity of the foot, posterior medial transverse crease, presence of posterior medial transverse crease, the cutaneous constriction band. The poor prognostic factors we have identified. Next, please. The aim of the treatment of club foot is to get a painless plantigrade normal looking foot with a good functional mobility. We cannot promise a total normal foot, but it should not be, it should be explained to the patient, and that it's a vitro deformity. The treatment varies from the conservative to surgical. In surgical, invasive treatment to semi-invasive, and in invasive, it is a limited invasive and very extensive invasive. Next, please. As far as conservative treatment is concerned, the gentle, passive, repeated manipulation and retention in the CDL casting. It is usually the weekly casting. Last one, please. The weekly change of the plaster is required. It should be started as soon as the diagnosis and the skin of the child is fit for the plaster. We have Ponseti technique. We have French functional method by the physiotherapist, but the Ponseti is the gold standard. Any rough manipulation may tear the taut ligaments and the soft tissue, which will cause scarring and stiffness. So it should be passive but very gentle, repeated manipulation, and it should be maintained in the corrected cast. Next, please. The concept of Ponseti technique is the functional anatomy. That they say that the fulcrum of the problem is at the head of the talus, because the tarsal joint are functionally interdependent. So the varus, inversion, adduction at the hind foot correct simultaneously with that of the forefoot. So the Piranis, the Ponseti said that we need not to correct the hind foot. The correction of forefoot will automatically correct the hind foot. The cavus, which is a deformity usually in the children which are presenting late. So we have to do the first metatarsal plantar flexion is the first step, means to increase the supination. Increasing the deformity is the first step. As far as the biology of the muscles is concerned, we have the crimps in the ligaments of the neonates, and these are very helpful in the gentle stretching and the healing of the ligaments without any scarring. The crimps appear a few days later, allowing further stretching. This is the reason why we should do stretching after 7 days, as recommended by Ponseti, and not 15 days as it was Kite's opinion to change the plaster after 15 days. Next, please. The common errors which was done by Kite in their manipulation, that they did the eversion of the foot, and which increases the deformity of the hind foot. Any attempt to push the calcaneum into eversion without abducting will press the calcaneum against the talus, and this will not allow heel to go into varus. And if we will press too hard, then the cartilage of the talus as well as calcaneum will be damaged, and the chances of stiffness of the foot will be improved. Next, please. In about 85% of Ponseti technique, we after the correction of the forefoot and hide foot manipulation, we go for 80% tenotomy. Tenotomy can be done open. It can be done under GA or local anesthesia open, or we can go for Ponseti. In 2014 and 2015, two studies was done, and ultrasound was done to find out what is the extent of tenotomy, and they found that only 44% went for the complete tenotomy, and rest 66%, I mean 56% were having incomplete tenotomy. But they found there is no correlation between the amount of tenotomy and the mean dorsiflexion and the recurrence of the equinus. So they said that even if with the incomplete tenotomy, but if we are having 10 degree, not 10%, but 10 degree of dorsiflexion, we will get a long-term satisfactory results. The Nikki H et al. In 2013 found that there is no correlation between the tenotomy and the calf atrophy. Next, please. Literature says new techniques without tenotomy to get 10 degree of dorsiflexion. First, which in 2015, the Adachi and et al. Described the dynamic dorsiflexion splint, and they said without tenotomy they get in 16 out of 18 children. Other study by Horan et al. In 2015, in which they gave Botox injection is the gastrocnemius complex, which corrected the lengthening of the tendoachilles without tenotomy. And but these two techniques are very new technique, and they both require more studies to establish themselves. Next, please. As far as the maintenance after the Ponseti is concerned, the bracing is the most important, and the dynamic articulating foot abduction orthosis is very important. And it is said that if we use the dynamic articulation foot abduction orthosis for mean 29 months, then if the parents are compliant to your instructions, then only 7% will be showing the recurrence against the 40% if we are not having dynamic articulation foot abduction orthosis. Next, please. Few new studies are there which predict the treatment resistance and higher chances of surgery. The Goldstein in 2015 found that the female are more resistant about 5% over the male. The Samir Adams sign, that is the great toe extended in comparison to other toe due to the presence of flexor digitorum accessory longus. In 2015, this sign was by the Shashin, and if this sign is present, there are high chances of failure of conservative treatment. If we are having poor reverters, as told by the Jelfer et al. In 2015, the higher chances of operative or the recurrence. If on X-ray we are having tibiocalcaneal angle more than 77 degrees or talocalcaneal angle less than 29 degree, as described by Shabtai et al. In 2015, or in lateral view, stress dorsiflexion is less than 16 degree as by the Holleran CP in 2015, then there are high chances that the treatment, our conservative treatment will fail and we will go for surgical intervention. Next, please. As far as the indication of surgical treatment is concerned, the failure to achieve satisfactory clinical and radiological correction by conservative treatment, neglected, relapse or resistant are the indication of surgical intervention. Up to 3 to 4 years, if we require intervention, then the soft tissue surgery. Beyond 4, soft tissue as well as bony articulation. Before 8 years, we try to preserve the joint. After 4 years, we can involve the osteotomies involving the joint. And after 12, the triple orthodesis is the choice. Next, please. If we are going for surgery before 3 months, then there are chances of excessive scarring. So the ideal time is between 9 months and 1 year, because the structure will be large, the chances of fibrosis will be less. The anatomy of the bone will be more easy to evaluate and to correct, and the repair will be more secure. In 2007, the KBOS observed that if sufficient correction not obtained by the end of 3 months, a soft tissue release at early age offer good prognosis, but because the structure are very fragile at this age, then the repair, it is very difficult to retain. So majority of workers are saying that it should be delayed, and unless until very alarming, we should not go for children in less than 3 months. Next, please. If we are going for soft tissue surgery, which technique we should go for? We have the most popular posterior medial top release by the turquoise, or limited soft tissue release and complete subtalar release. Next, please. We have 2 types of incision for posterior medial soft tissue release. That is Cincinnati incision. It's a safe, extensile, cosmetic. But the problem is in severe equinus, the placement of the incision is very, very difficult, and we have to place the patient in the prone position. Longitudinal incision is also described, but it is not very cosmetic, and the chances of skin fold necrosis are higher in this longitudinal incision. Next, please. In 2005, the Lucchesi in a 10-year follow-up observed that the skin closure after the Cincinnati incision is difficult in comparison to the 2 incision or the L-shaped incision, and they found that the closure was augmented in majority of cases by VY local fasciocutaneous flap, all primarily closed without any complication after this fasciocutaneous flap, and in majority of patient, no plastic surgeon other than this flap was required for any other secondary procedure required for the closure of the wound. Next, please. Now, what are the causes of the recurrence? A complete correction verified by radiological and clinical evaluation usually stays corrected unless until the non-idiopathic clubfoot is concerned. The causes are the failure to maintain the correction while normally oriented bones remodel stable articulation, the persistence of primary deformity, that is the articulation is not properly corrected. If scar tissue has formed because of surgery or a rough handling of the soft tissue and the stretching, And if there is dynamic imbalance because of involvement of spinal cord, that in 18% of our cases, then this imbalance will cause the recurrence of the deformity. Next, please. There is some role of tendon transfer in some select cases, that is tibialis anterior. Tibialis posterior has a very, very limited space in club foot, and if it is used, so then it may cause the plano valgus. Tibialis anterior is used after using full tendon or the half tendon, uh, and the other is the 3 incision or the 2 incision. The weakness or the absence of peroneus longus and peroneus brevis is the indication of dynamic supination for the tendon transfer. No statistical advantage of FHL and digitorum longer lengthening as described in 2009 by Lohati. Next, please. We have limited role of ligamentotexis in our neglected patients. We have Jess for the ligamentotexis and Elizarov. There is a literature full of in praise of Elizarov, but our experience in India with Jess is good because in Jess we are not using axially tensioned wire, and the frame is unconstrained. Next, please. Little bit about the complete subtalar release, which was described in America. They say that the calcaneal rotation in club foot is in 3 planes. So they said a concept to derotate the calcaneum from the talus, and we have to do the total subtalar release along with posteromedial soft tissue release. If we will not do the subtalar release, then that will act as a hinge. But McClay preserved the interosseous ligament, and Simon divided it also. If we divide the interosseous ligament, then chances of a risk of cross translation of calcaneum over the talus are there. So it is, I think, the McClay's preserving of interosseous ligament is recommended. Next, please. Indication of complete subtalar release are for varus and adduction deformity, but it is not for equinus alone. The foot at least should be 8 to 9 centimeter, so that we are having a proper anatomy, and it preferably should be less than 4 years old child age. That contraindication is the stiff ankle and the complication of overcorrection of valgus or translation of calcaneum over the talus. Next, please. The gait analysis is nowadays is very important, and we have found the abnormality of the gait analysis, and it is corrected by the conservative treatment as well as by the surgery. But still the internal torsion persists after the correction of the foot deformity, and so the foot progression angle remain less in most of the cases after correction, whether conservative or the surgical. And if the internal torsion of tibia is asymptomatic, need not to do anything. Otherwise, we have to do the derotation osteotomy of lower tibia. Next, please. As I have told, we do not have any long-term evaluation to assess our long-term results and the outcome, because we need a perfect system which give us clinical, radiological, biomechanical, and gait analysis. So we should work on to evolve a long-term evaluation, so that we can predict the natural history of the most of the club feet. Next, please. thank you very much for giving me this opportunity. Thank you very much.
Thank you so much, sir, for this elaborate lecture. Professor N.K. Das, would you like to ask something? N.K. Das, sir?
In the meantime, our Secretary Dr. Partho Sarthi Sarkar has joined. Our Vice President Dr. Anidho Sen Gupta sir has joined. Welcome. Sananuda has joined. Welcome, Sananuda. And any question?
Yeah,
Abhishek?
yes, sir. Sir, there was a theory, either there is a defect in the soft tissue or in the bony tissue.
Primarily, the problem is in talus.
Yes, sir.
And all the soft tissue and the ligaments are responding to the abnormality of the talus, and the main problem is talus and its articulation with the navicular. So you will say the primary problem is osteoarticular, and the secondary changes are the soft tissue, muscles, and the ligaments and the tendons.
Sir, do you have any literature in which the collagen fiber of the medial tissue or collagen fiber of the tendoachilles are something different?
No, I think I have searched, but no such ligaments, microscopic histopathological examination is done in any of the thing, except they have done studies, and that when the normal structure of the collagen appear after the tenotomy, and
Yes,
they
sir.
found that completely normal tendon appears after abnormality in the tendon as such is not studied as such.
Okay, sir. Thank you so much, sir. Any other question from other faculty? Abhishek, would you like to ask something? Dr. Nandi?
No, sir, nothing for now. Because most of the things which I was about to speak, sir has already spoken. So
Yes, sir.
it was
Sir
quite
has almost covered every one topic.
It's an extensive lecture. Thank you, sir. So just one question can I ask, Akhilesh sir? And
Yeah.
yeah, sure. I just wanted to ask regarding the two grading system that we have, the Dymelio and the Pirani. So which one do you prefer? Like, we all prefer the Pirani system. Dymelio, honestly speaking, I think it's a far more extensive evaluation system, but we are not adept at using it. So I think that's the reason why Pirani has stole a march over everybody. Like we all have been trained in doing a Pirani evaluation in
Actually, when Pirani gave this grading, that was given for the non-ambulatory children. So the Pirani score was described for the non-ambulatory. But in our part of the world, it is very difficult. I mean, we are getting too many patients late coming. So we are also using Pirani for ambulatory, but ideally that should not be done. The Demilgo should be go for such patient. But because, as already you have said, it is not practically, as far as OPD is concerned, it is very difficult to assess Demilgo classification, and routine work, it is very difficult. So we go for Pirani, and we, I think AIMS New Delhi is doing some studies in which they are finding the role of Pirani scoring in neglected clubfoot in older children. We are sticking for Pirani only, even for ambulatory children.
NK Das sir, Chirmede sir, any comment?
So everything is nicely described. I have one query. Long back, when we were practicing in medical college, kite method was the only method we practiced, and lots of cases we done by kite method. Now came the quantity. My question is whether any long-term study, comparative study between the kite method and Pirani method, so that it can be proved that the quantity is superior than the kite method.
Yes,
The
sir.
sound.
There are many studies now which gives not only the clinical and neurological parameters, but biomechanical parameters are being studied, and they found that only the cost, not only the cosmetic correction, but the main correction by the Ponseti is the correction of the articulation of various tarsal joints is much better in the by the Ponseti over the French technique or the kites technique. And so they found that the recurrence which was uh, in the kite around 41% is in majority of new studies that has around 9% or 10% by the Ponseti. So there are studies which have and that they have given the reason that the articulation of the talus and the navicular and other tarsals is improved much better by the Ponseti than the kites.
Please, that we can move to next talk. Yes.
Abhishek, now it's your topic. Topic is assessment and classification. Dr. Nandi. Ajay, please stop the Ajay sir screen.
Yeah, already I stopped.
Oh, Abhishek, now you share your screen. Dr. Nandi.
I'm not getting the option. Can someone stop?
No, now you will get. Yeah. Try. Any issue, Abhishek?
Yes, I'm not able to share it. The option is not coming, sir.
It's there. You can share. See, it's multiple option there.
I'm getting scheduled, that is highlighted, but share is not getting highlighted.
Share screen green button is there. You can share from there.
No, sir, I'm not still getting it.
Issue is there.
Yes, sir. Schedule is highlighting, but the share thing is not highlighted.
There is any option like share screen?
The option is there, but it is not highlighted, sir. The schedule meeting is highlighted, but the share is not highlighted, getting highlighted here.
So, Lejda, you start. You try sharing your screen. I think we can start with your. After that, we can see it.
No, Dr. Ritesh will before me,
Ritesh.
because I will do the tenotomy part. So, Dr. Ritesh, would you like to start? In the meantime, the snack will be corrected by Abhishek.
Okay, I'm starting here. Yeah. Is it visible?
Yes, sir.
Yes, sir. Abhishek, you
So-
mail your presentation to me. I will try to share from my laptop.
Okay, sir.
I'm sending my email ID.
Yes.
Yeah,
please.
thank you to West Bengal Orthopedic Association for organizing this seminar. So I'll be talking about plaster technique, as Dr. Ajay has already discussed about various techniques. So now Ponseti technique is mostly practiced almost everywhere around the world. And I'll show a video of plastering technique in this child presented with clubfoot, bilateral clubfoot. So this is the video. So this is our plaster room where I am holding the foot and the leg. And basically I am holding the great toe and the knee, by which we are stretching the medial soft tissues and keeping the foot in plantar flexion. So as highlighted, talus should not be locked under the calcaneum. Calcaneus should freely move. While applying this After all, it should go up to the groin, deep inside. Therefore, we have removed the nappy pad, and this we make sure that this cast padding goes up to the groin. Otherwise, the plaster will be short. It's just like holding a great toe, which keeps the medial soft tissue stressed. As advised by constructive, 5 rolls, then first layer of foot casting is done, and slab is applied on the medial aspect and on the plantar aspect, because we'll be putting pressure on these areas, and we try to retain the abduction and to hold the metatarsals in line. What I have noticed in my practice that getting a good assistant while applying a cast is of utmost importance. If we don't have a good assistance, then it is a big problem. And by sitting down, what I try to ensure that the bias of creating dorsiflexion is lost. So here, due to the position of the person or the surgeon, we can create a plantar flexion, then supination, and you can notice the thumb under the metatarsal heads and one thumb over the first metatarsal head. At no moment of time, metatarsals are left so that the first ray pronation is recreated. Whole foot is in supination and trying to put one finger over the fulcrum, that is the head of the talus, and by other hand trying to stretch the medial soft tissues. I have seen some other surgeons while applying this cast at this stage, while molding a stage, the left hand, which is behind, they put the index finger around the calcaneus to create the shape of calcaneus or shape of the heel. Here we have applied the lower part, and now the leg is in external rotation. Now the leg is in external rotation and knee is in 90-degree flexion. This part of plaster should be up to the groin so that whatever while passing a stool or urine, it doesn't goes inside. And the risk of plaster slippage also reduces. Using the left leg with the left hand in external rotation, gentle external rotation, the person who is applying the plaster gets adequate space to apply the cast.
Fibrous dysplasia, बोन जो है धीरे धीरे सॉफ्ट होने लगता है।
Yes.
एंडोथेलियम जो अंदर का जो बोन है वही सॉफ्ट होने लगता है, और ये बहुत ही मतलब वार्म कंडीशन है। क्या है कि हड्डी बहुत गर्म रहती है। फाइब्रस डिस्प्लेसिया में तो हड्डी जल्दी टूटती नहीं, टेढ़ी हो जाएगी लेकिन टूटेगी नहीं, जल्दी नहीं टूटेगी। लेकिन फिर भी जिस एरिया में इनको है पेन, वो वेट बेरिंग जोन,
So
वहीं से कैलकार जहाँ से आता है,
only the foot was
वेट
corrected.
ट्रांसफर होता है एकदम उस।
Here I want to show that for creating the at the fulcrum we are keeping the thumb, two-hand technique while manipulating. This is for the metatarsal support. So one by one, at no moment of time we are leaving the foot without metatarsal support and without the finger over the fulcrum. And here we are stretching the medial soft tissues, keeping the foot in pronation and abduction. Thank you.
Okay. Thank
Is
you,
it
sir. Sir, is it the first plaster? First one, or you have?
No. This one is, I think it is second or third plaster.
Okay, sir. So then, why pronation in second or third plaster?
So it depends upon the correction. It's not fixed that once we apply a plaster, it should be another plaster or third plaster. Depending upon the correction, what we have achieved. And as you can see, this was a walking child. So walking child already have a stiff foot. And they were walking, there was a lateral callosity also. So in second plaster, we try to repeat the first one only if adequate correction has not been achieved.
Your protocol is something different in newborn baby?
In newborn baby, I try to wait for 1 month because many times I have seen that people are rushing to hospital that immediately after birth, second day, third day, they are applying plaster. But my protocol is to wait for 1 month, 4 to 5 weeks, and then I start applying plaster.
Why, sir? Why you are deviating from normal protocol?
I don't think it's a normal protocol because waiting for 4 weeks doesn't change any difference in outcome of the plaster. Second, applying plaster at 4 weeks, already the baby skin has become tougher. It has adapted to the new environment while the baby was in mother's womb. The skin was soft. Third, I try to judge the patient whether they stick to a person or not. Many a time, suppose we send the patient back or we start applying the plaster, the patient will not come second or third time. Now the patient is lost in follow-up. So I judge that whether the patient, if the patient relying on you, will come at 4 weeks. And it is not going to make any change in the outcome.
NK Das sir, Ajay sir, your opinion on this?
Probably this is not right.
As far as I am concerned, I start as early as possible, maybe after 2 weeks. I start. My only criteria to examine the skin of the child, if skin is healthy enough and child weight is good enough, I will not wait for 4 or 5 weeks. I will start it. As Dr. Saab has said that it is not going to cause any long-term problem, but I agree with that. But actually, as early as you will start, it will be lesser amount of manipulation and lesser number of manipulation. Maybe in 2 or 3 manipulation only you will correct. So my protocol is different, but if he feels that after 4 weeks he's getting better, then I'm okay
Not
with that.
something so better, but I think that there's no difference in outcome because
Right.
it still will take 6 weeks to get corrected. By 2.5 months, the child is okay, and by 3 months, yes.
My question is whether you advise something for your 4 weeks, or you just advise nothing during initial 4 weeks.
Yes, Dr. Deepis, I've got a question against to my friend Ajay. Welcome. So I was joined. I just joined a bit late. Because if you wait for this 4 weeks time, because do you advise some sort of strapping or just train your
Yes, yes.
train the
Yeah,
muscle,
that I,
train the
that I
muscle
was
that
telling.
is the manipulation should be there, because by 4 weeks time you will basically losing the actual period of the recommended time period.
See,
Right.
what I was telling that this 4
Right,
weeks
right.
is not fixed time, but once the patient reports on second day or third day of the birth, so usually I ask the parents to keep on doing gentle manipulation,
Yes,
which
yes.
we treat the patient. And for 2 weeks or 3 weeks, we ask the patient to come back. If the patient is reporting back by 3 weeks, we start applying plaster. But suppose a patient is coming by 4 weeks, so I don't ask them. It is not rigid protocol that you have to come by 2 weeks within 2 weeks. So there is no rigidity, but during that period, I ask the patient to go for manipulation.
Dr. Ritesh, and a question to Ajay sir and also to our Professor Chinmoy sir and Niloy sir. If you take these guys like what you saw in your the Ponseti plaster technique, this weight bearing group, how you decide that the point of your pterotomy, or how you decide? We on the first day you do it, or how you decide to go ahead?
No. May I answer? May I answer?
Yes, yes.
Yeah. As far as the indication of tenotomy are there, first thing we have to get at external rotation from 40 degree to 60 70 degree of external rotation, means the forefoot and the hind foot is fully corrected, number one. As far as Pirani score is there, the Pirani score 0 is the mid-tarsal joint, and the hind foot score is more than 1. And if we are not having dorsiflexion of less than 10 degree, these are the 3 indications when we have to go for tenotomy.
No, that is the classic indication, probably, Dr. Ajay, that you were telling of the when you are doing the newly or the newborn kids or like 2 weeks, 3 weeks time. But as Dr. Ritesh was showing, this is a older child age group. Do you do for the that question was specific to that?
Basically, when we get the walking child, so in walking child also, before going for tenotomy, we have to get forefoot correction. So once the forefoot is corrected, we get more than 40 degree of abduction. If the not if it's a typical foot, then more than 40 degree. But if it is a typical normal idiopathic clubfoot, somewhere around 60 to 70 degree abduction, and forefoot is well corrected. Hindfoot is there TA tight. Heel varus has corrected on abduction. Then we go for tenotomy.
No. Older means how much older you are talking?
We have applied plaster up to 8-9 years old child also.
Because in 8-9 years, only tenotomy will not sufficient. You have to do lengthening and release of the capsule also. Highest age, what the Dr. Mosca described, up to the 2 year for the tenotomy.
Yeah, but if you would, what I have seen in our practice, open tenotomy is done when the patient is reporting with the recurrence or the patient repeatedly relapse clubfoot, or when we get the fresh clubfoot, we are applying Ponseti technique casting. It may be more, it may be around 8, 10, 12 also. And when we get forefoot correction, then we go for tenotomy. And in tenotomy, we make it sure that we get 10 degree of dorsiflexion. If it is not, we don't get it, then we go for mini open incision. We do the tenotomy or lengthening, and then at least we have to get 10 degree dorsiflexion after that. That is our protocol.
Dr. Akhilesh, the question
Dr.
is
Samantha,
yes,
Dr. Samantha.
Yes.
Yeah.
Actually, if we are having very severe and stiff foot, and we are having a very tight equinus, then in some select cases we start with the tenotomy, so that we will be able to get some degree of correction of the equinus, and so that the plaster can be applied. Otherwise, if in fully equinus foot we will apply the plaster, then the chances of slipping will be very high. In those select cases, we start with the tenotomy first, then do the manipulation. Otherwise, the gold standard is the same indication of tenotomy after correction the forefoot and hindfoot.
The question is there that if you do tenotomy do you dorsiflex also, or you don't dorsiflex after doing tenotomy? If you are doing it initially.
Yes, you have to do. You have to do, because the success of what I have told in various studies, that it is not the complete or incomplete tenotomy which is important. It is the amount of dorsiflexion you are able to achieve. If you are able to achieve dorsiflexion of pivot, if you are not able to get it 10 degree, so you have to do the manipulation after tenotomy. Yes.
Dorsiflexion on the day one you do, na, Dr. Roger. I think you have,
Yes,
if you do the tenotomy, you have to go for the dorsiflexion.
Yes, will, of course.
But
Yes.
without getting forefoot correction, then there is no derotation, because for derotation, calcaneus should be there attached with the TA. If we had dorsiflexed it, it will get locked with the talus.
I'm talking about a special case in which equinus is so tough that you are not able to get the plaster and the foot is in line of tibia only. In those conditions, I'm telling, otherwise the gold standard will remain what you have told.
We can go with our next case. Yes.
Is there any
doctor? Actually, in my opinion, the treatment to be started as early as possible, preferably on day 1 or day 2. I do personally start my treatment whenever the patient come early on day 2. Why not day 1? Because in the day 1, the baby comes from a different environment. Just for acclimatization of the environment from mother's womb to exterior, you just give 1 day time, and within these 24 hours, in most of the cases, the skin of the foot is good enough for application of a plaster. And if you start the treatment early, then you will find in most of the cases, 3 plasters are good enough for correction of the deformity, and quite a large number of cases there is no need for tenotomy. Only around 50% case require tenotomy. But if you start the treatment after 1 month, then definitely the requirement of plaster is much more, and you will feel much more problem in correcting the deformity. Ultimately, the result may be same. There may not be final outcome alteration, but the number of plaster requirement will be much more if you start the treatment late.
Yes,
so my
yes.
opinion is it should be started as early as possible.
Yes, Professor Das, I completely agree with you. It is as early as possible. That idea has not been changed in the last 35 years.
And it's on the day 1 or day 2.
Day two.
Day 2.
Day 2.
Yeah.
Yes. Rajiv, Dr. Nandi, ready? His screen is ready.
I think I have not got
classification and assessment of CTEV.
I think you can start your screen sharing. By that time, it is being downloaded. Yes, it is done. Yeah. Abhishek, make it in presentation mode.
Am I audible, sir?
Yeah.
Done.
So my topic for discussion is congenital talipoequinovarus deformity, the types and the assessment. So what are the deformities in CTEV? In hind foot, in ankle there is equinus. Subtalar joint is in 42-degree angulation, so there will be inversion plus adduction, which we say as hindfoot varus. In midfoot, that is the mid-tarsal joint, there is forefoot adduction and plantar flexion with respect to hindfoot. So these are the diagrammatic pictures of cavus, adduction, varus, and equinus. So there are different classes. The postural, which is mildest and corrects with manipulation. The idiopathic variety are the most common. Neurogenic variety, as shown in the picture, are associated with MMCs. And there are associated syndromes like arthrogryposis, Streeter's dysplasia, Prune-Bailey, tibial hemimelia, Freeman-Selden, and Perry-Robin syndrome are associated syndromes with CTEV. So if a child presents with apparent clubfoot and parents are asked about the child's treatment history, if the child has had a Ponseti clubfoot treatment and foot is not corrected, so we call it a resistant clubfoot. And if the foot is corrected, we call it treated. And if the deformity recurs after correction, we call it recurrent. So if the child had never come for CTEV treatment And if the child is under 2 years, we say untreated. Whether if the child is over 2 years, we say neglected. So what are the various theories? So there the theories which are given, given are the in utero molding theory, where there is a difficult in utero molding which causes CTV, the primary muscular lesions, the germ plasma defect, the primary vascular lesion, the intrauterine endoviral infection. So that is one of the infection which is associated with CTV, the enterovirus. Developmental arrest, primary nerve lesion, abnormal tendon insertion, which caused that retracting fibrosis, which Akhilesh was saying about, and the abnormal histology to confirm the fibrosis. There are associations that smoking is what Sir told, and it was reported by Skelly and Hoyne, and the increased ligamentous laxity, both are associated. So what are the role of X-ray? So generally in CTV is a clinical diagnosis, but there is a role of X-ray. So X-rays are generally done for planning of surgery, so that we know the exact site of residual deformity. In intra-op, we can see the adequacy of correction by noting the position of the heel. And a diagnosis of midfoot break can be confirmed using a stress view. And also, while doing a forced dorsiflexion, there are chances of flat top talus, which is usually evident by Elizarov. The C is the fixed position of the foot in equinovarus position, and it is done in a sequential observations. Now, what is complex CTV? In complex CTV, there will be a significant shortening of the forefoot. There will be rigid equinus with deep posterior crease. There will be a severe plantar flexion with deep plantar crease across the full width of the sole of the foot. It will be a high cavus type. There will be short and hyper extended great toe, and the neurology will be normal. So this is a case which we can say a complex CTV. You can see the great toe is extended and it is short. We can see the rigid equinus. So we'll come to the management part later. So what are the etiopathogenesis? So it is the bones, joints, it is the capsule, ligament, it is the muscle tendon which is involved. Actually, it is amalgamation of all the three. So if you see if you see this model, it shows equinus. There is a severe tibiotalar and taloplantar flexion. The varus is created by adduction, plantar flexion, and inverted calcaneus. And the adduction is created by medial talar neck inclination, medial displacement placement of the navicular and the cuboid, where the calcaneus is adducted, and distal calcaneal articulating surface adducted. And forefoot is also adducted. So how talus behave in CTEV? So this was taken from Taxian. So if you see talus from superior, the anterior pole of the talus will be medially deviated. If you see the talus from the anterior, it will be dorsal, it will be plantar flexed. If you see from medially, again, it will be internally rotated. So this is taken from Staheli. So if you see the axis of the tibia and the talus, it should be normal 160 degree. But in CTV, decreases to 120 degree. This is the normal calcaneus. In CTV, it is medially deviated. And also it is, it is intorted or pronated and inverted. The position of the navicular, there is a displacement. There is a medial displacement between the talus and the navicular. And there is an uncovering. Cuboid is also displaced medially. And there is a shortening of the first ray. So what is the soft tissue contracture associated with CTV? If it is equinus, the structure which are contracted and contributing are the tendogastrocsoleus, the posterior capsule of the ankle, and the posterior part of TFL. With the hindfoot varus, it is the tibialis posterior which is contributing, the medial capsule and the calcaneofibular ligament. The forefoot adduction is created by tibialis posterior, abductor hallucis, and spring ligament. And the forefoot cavus is created by plantar fascia contraction, and short plantar muscles. So what are the conditions, the abnormalities, and how we go about? If it is a congenital clubfoot, so tibialis posterior and gastrosoleus contraction along with talus and the calcaneus deformity. So it is ponsati and some releases. If it is a CP palsy, we have to restore the muscle balance. If it is a CP, it will be associated with spastic gastroc and tibialis posterior, so release is required. So this is taken from the textbook of Benjamin Joseph. He has given the different axes of the subtalar joint and the ankle joint. If you can see, this is the subtalar joint axis and this is the ankle joint axis. So if you take the ankle joint axis, tibialis anterior, EHL, EDL, and similarly tibialis posterior and peronei and also the Achilles, they are plantarflexing. Sorry, they're dorsiflexing and these are plantarflexing. On the other hand, if you see the subtalar joint, the tibialis anterior, tibialis posterior, and the Achilles, they are all doing inversion. And the peroneal and EDL are doing eversion. So the different ligaments and capsular which are involved in CTEV are the deltoid ligament, the posterior talar ligament, tibiocalcaneal ligament, the spring ligament, the plantar calcaneocuboid ligament, the calcaneocuboid joint capsule, the plantar cuboid navicular ligament, plantar tarsometatarsal, and the plantar cuneo navicular ligament. So assessment. So we had a discussion on diamigalo versus Pirani. So diamigalo is definitely more objective, but we are more fond of Pirani. So in diamigalo, if we score, there are four parameters which we see in diamigalo. In sagittal plane, we will measure the equinus. In frontal plane, we will measure the varus. In horizontal plane, we will measure the calcaneopedal block and also the forefoot evaluation relative to the hind foot. So it is evaluated between -20, 0, 20, 45, and 90, and we are scoring it between 4, 3, 2, 1. And other parameters which are additional are the posterior crease, medial crease, cavus, and poor muscle condition, which are given 1 point each. Now, if the score is less than 5, we grade it as 1, and severity is mild, and we say it is a soft foot. If it is a 5 to 9, we say moderate. It is a soft, stiff foot. If it is 10 to 14, we say it is a severe variety. If it is a stiff and soft foot. Above 15, it is very severe variety, and we say it is to be a stiff foot. So coming to more, this is a more common scoring which we do is the Pirani scoring. So we see the lateral border of the foot, the medial crease, and the talus head. These are all the medial midfoot scores. The hindfoot score are the posterior crease, rigidity, and emptiness of the heel. So we are assessing if the lateral border of the toe touches, we say it is a 0. If the middle of the foot touches, we say 0.5. And if it is nothing touches, only the end of the heel touches, we say it is 1. So the medial crease, if it crosses the midline, it is generally 1. If it is just about to enter the midline or just stops before midline, it is 0.5. The uncovering of the talus is pure subjective. The posterior crease again is the same. If it is just crossing, if it is a deep posterior crease, we say 1. And if it is a superficial posterior crease, we say 0.5. So dorsiflexion, if it comes to neutral, it is 0.5. It comes to more than neutral, then it is 0. And if it is a rigid equinus, we say 1. The emptiness of the heel, there is only 2 score. It is again a subjective, where it is 0 or 1. So this is the sheet which we follow in our institute, where we evaluate all the patients, and monthly we generally follow the accelerated Ponsati, where we cast twice weekly, and we follow this sheet for evaluation. So a rough management, if a patient comes at birth, infancy, or childhood, so generally Ponsati approach is used. We do cast, we do percutaneous heel tenotomy. Then again we do cast post tenotomy. Then if required, we do lateral transfers and observation. If French approach was, again, it was a daily manipulation thing, and holding splints were used, which is not commonly used. But the thing is arthrogypotic foot. As Sir told, that there are reports where we have done early tenotomies, especially in case of arthrogypotic foot, where the tendoachilles, it shifts medially. So it does not dorsiflex the ankle, but it acts as inversion. So the heel becomes inverse. Inverted and varus. So in those situations, if we do early supination, which we will do while correcting the deformity, that supination will be easier. So in those cases, we have reports where we have to do early tenotomy before correction of the midfoot or the midfoot score to
Abhishek, there is some issue with your screen sharing, I think.
How long it is?
Make it in presentation mode. It will run from that slide. Yes. Hear you.
There is some
Hello?
network issue.
Yeah, some network issue is there. I think by that time, Akhilesh, you can start your screen sharing.
First, he have to stop his screen, otherwise.
I will do that for you. You start step screen sharing, it will automatically replace. Akhilesh.
Now it is visible.
No, I think yes.
Yeah, now it's okay.
Yeah, visible.
Yes, and you are audible also. Please.
Yeah. So my topic is tenotomy of the tendo Achilles in the CTEV. As the earlier speaker has elaborately described everything, and this is also one of the most important part of the Ponseti technique. So the ideal time for the tenotomy when the cavus, abduction and varus are fully corrected, preferably after fourth cast. It can be done after third cast also, but I usually do it at fourth cast. And this is the baby in which the four cast has been done, and now he is on the operating table for the tenotomy. And you can see in this foot there is some heel varus is not corrected, otherwise this foot is ready for the tenotomy. And so after tenotomy, sometimes this heel varus will also correct, so you can go for the tenotomy even there is some slight deformity is there. So indication for the tenotomy: when ankle dorsiflexion remain less than 10 degree above the neutral, it's required in the 85% of the cases. That is the data from the Ponseti, and it may vary from person to person. And upper age limit is 1 year. In some book, it is also up to the 2 year. So steps of percutaneous tenotomy, what I prefer is a short general anesthesia, because I have one children hospital and their anesthetist is accustomed in doing such anesthesia. So I do in general anesthesia. Can be done under local anesthesia. I prefer needle number 16 for less than 3 month age and number 15 blade for older one. Face of needle or blade should be parallel to the fiber of the tendo Achilles to avoid the posterior neurovascular bundle injury. And saphenous vein and sural nerve are at risk on lateral side, so do not drag the knife. I will come to that part. So first you watch the video. The most important part is the localization of the ideal part of for the tenotomy. It should be ideally 1 to 1.5 centimeter above, but with your index finger just you point out the most prominent part and introduce the needle with his beveled end anteriorly. So just palpate here the highest, then you can see how I am introducing the needle. The beveled end of the needle is anteriorly. and enter through the medial side. First touch the tendo-achilles belly, and then you enter in the soft tissue and then translate the needle. Do not drag the needle. And this is the pictorial method. Do not enter through this soft tissue space. Also, do not enter through this free space. Just hit your scalpel to the belly of the tendo-achilles, and then you go inside the soft tissue, just touching the anterior border of the tendo-achilles. Then you rotate your knife to the 90 degree, and after rotating your knife, just rotate scalpel 90 degree and translate posteriorly. Release you can feel by the pop sound. And these are the pictorial space. And this is the first foot, and you can see the adequacy of the tenotomy. And now the second foot is doing in the same manner. Just you see the needle. I will again show you see how I am introducing the needle. Now you can see here. Just I am removing the needle for demonstration. Just then I introduce it beveled end anteriorly. Then rotate the needle. The edge of the needle is now cutting the tendo-achilles, and just translate. Now we will hear a sound. This pop sound. This pop sound is confirmatory of the tenotomy. And this is judging the adequacy of the tenotomy. At least 15 to 20 degree of the dorsiflexion should be possible after the tenotomy. And you can see in both view, these are almost corrected. After doing the tenotomy, few minute gauge pressure, then these three are the prerequisite. 10 degree of the dorsiflexion, and 70 degree of the thigh foot angle. That is very important. This is the thigh and this is the foot. So your foot should be 70 degree and long leg cast, not short cast. And this should be kept for at least 3 weeks. And after 3 weeks of tenotomy, you can see almost all deformity is corrected, and even without any pressure, this foot is almost in correct position. And with slight pressure, it goes beyond 10-15 degree of the dorsiflexion. And this is the one of the most important step, the bracing, that will talk by the other speaker. And at present, the Dennis Brown type splint is the best. And why tenotomy is essential? Because it has been said that due to less remodeling potential of the tendo-achilles collagen, if you do not do tenotomy, there may be increased chance of recurrence. And another thing is that if you do not do tenotomy and you do the forced dorsiflexion, the cartilage tendo-achilles will be crushed, and then there will be the flattening of the talar head. This is one of the my case, and you can see this is the CTEV foot. And this is shorter foot, because this is longer foot and this is shorter foot. And you can see the talus. There is something flattening of the talus. So in this case, I do not do the tenotomy, because 5-6 years earlier, tenotomy was not that popular. So you can see the clear difference between of the forced dorsiflexion. This is the normal talus and this is the flattening of the talus. So by tenotomy, you can also prevent this. Thank you so much. Thank you. Any question?
Yeah, I have one question that recently, a few reports I have heard, I've read about that. After tenotomy, they are applying 2 weeks of cast or 1 week of cast and then applying the brace. Is it okay or?
No, sir, because for the collagen tissue to mature, because you are relying on the fibrosis, there is no regeneration of the tendo-achilles. So you are relying on the fibrosis, and with time, this fibrosis is also converted into almost normal tissue. So 3 weeks, the at least time you have to keep the for plaster.
Okay. We are following the same protocol.
May I add one thing?
Yes, sir. Yes, sir. Most welcome, sir.
May I add one thing?
Yes, sir. Please, sir.
Most welcome, sir.
Yeah, actually, it was very well explained how to perform tenotomy. in cases in a very severe type of clubfoot such as Pirani 5-6 or in arthrogryposis, we should not do the percutaneous tenotomy, but we have to perform the tenotomy under direct vision, whether in under GA or the whether under local anesthesia. But we have to identify the tendon and we have to preserve the vessels. Percutaneous in such severe cases is not advisable. So we have to take precaution in these cases.
I want to share my experience, sir, here, that in 2 of our relapsed cases after tenotomy, patient came back with equinus. So in those cases, I was in Meerut. So we did a mini open tenotomy. I opened the area with 1 centimeter incision, inserted the artery forceps. I found that there's a wide tendon, wide tendoachilles. So many a times in these cases, which are severe, by doing percutaneous tenotomy, we leave some sleeves of the tendoachilles, which matures and then again creates the equinus or adduction deformity. So in cases of relapse, we should go for mini open, take out the tendon on artery forceps and completely do a tenotomy. Yeah. Thank you, sir, for highlighting this point.
Akhilesh, now we can go with our next talk. Yes.
Abhishek, your topic, bracing and detection of early recurrence. Abhishek Saha. And after that, we have also one tag, the common operative management by Abhishek Nandi. And that was the last.
I hope my screen is visible.
Yeah.
Yes. Abhishek, speak a bit loudly.
Yeah, yeah. Am I audible?
Yes.
Yeah. Okay. Good evening, everybody. I'll be talking on bracing and early recurrence in CTEV and how to diagnose that. My majority of my talk will be based on the bracing and the various way in which it is done, why we use the different type of braces, and a short glimpse of what to expect in the future. Recurrence, I have actually restricted a little bit because most of the speakers will be anyhow talking about the recurrence and the surgical techniques associated with it. Now, what we know that the bracing is critical for success of the treatment. And if you can't monitor the bracing properly, the treatment means nothing, because high incidence of recurrences are associated with non-compliance or poor compliance with the bracing. The recurrence ranges are as high as 90% in the first year to almost 5% in the fifth year, less than 5% or something. This is roughly a data which is based on certain articles that in the first year, if there is poor compliance with the brace, we have almost 90% of recurrence. Second year, it goes to almost 70 to 80%. And in the third year, we almost have a recurrence rate of 40% without proper application of the brace. Now, in these cases, roughly what we see is that it is not only just the data in which we have got because of non-compliance of the brace, whereas we also here have the data in which the brace was not properly worn by the patient. Now, what we see over here is in children under the walking age, the brace should be worn for 22 to 23 hours per day for 8 to 12 weeks. Now, night and sleep time until the child is 5 years of old. This is again a bit controversial because a lot of the people, they prefer 3 to 4 years, up to 3 to 4 years. And ideally, the brace should be applied when the last cast is removed. So this normally prevents the foot from turning back into its previous position. Now, coming to the brace fitting instructions, we are all acquainted with this. Now, removal of the cast post anatomy. Normally, the difficult foot should be fitted. I normally take my orthotist with me during the last OT, and we normally while fitting, it should be we should flex the hip and knee gently, dorsiflex the foot, and then maintain it in position. Push the heel first into the shoe with the straps undone, and inspect through the medial hole to make sure that the heel is down, and close the flap, the upper one, and recheck the laces or the straps and tighten the strap. In some of the braces which I'm going to describe, we normally fasten the middle one first, followed by the distal one, and followed by the proximal one. Now we have different types of braces here. We have the foot abduction braces like Steenbeck, DB shoes with brace, which is our common practice, which we use commonly in our practice. We have the Miracle Fit brace, the Mitchell, Markle, Iowa, and I'll be also talking not exactly about the braces, but also about a bit of the Padmapada, which was developed by our in our centers, and the Dobbs quick release bar, which is a recent innovation. Now coming to the Steenbeck foot abduction brace, we all use DB splint. I think it will be more apt if I talk a little bit more about the Steenbeck foot abduction brace, which is used extensively in the third world countries as well as the poor countries. Now here, just going through the basics of the brace, it is almost parallel to what we use in the DB splint. Now shoulder width of the bars, the shoes are attached to the bar at 60 to 70 degree of abduction, and 10 to 15 degrees of dorsiflexion must be achievable when we put it. The low posterior cut is done to the shoe to prevent the heel sleep. It should have a well-rounded heel cup, a straight medial border, which is again same with the DB splint. We have to have large shoelace holes or straps, and an inspection hole, which is mostly on the medial side. Now this is the Steenbeck brace. Now the good thing about this brace is that all these things can be fabricated at a very low cost. We normally can just manufacture this entire thing. There are templates available by which this can be made, as well as the bar that we see over here is also a pretty simple one, and which can be easily, while we are applying this brace to the child, or when the orthotist is fitting the brace to the child, that time we can just bend it and have a look that the foots are in proper abduction or not. Now there are two types of this brace. The type 1, which is the normal foot, and the type 2 is normally used for the syndromic or fatty and puffy foot, which are not exactly the routine thing like what Akhilesh just showed us some time back. So these are the two types of the Steenbeck foot abduction brace that we use. Well, it is not very popular in our country so far, because in our day-to-day practice, we are using the DB splint. We have been taught by our seniors how to use it, and we are far more familiar and comfortable with the DB splint. Now, this is our DB splint, the abduction brace, and the you can see the shoes in that. Now coming to, I just wanted to have a little talk about the other braces which we uncommonly use, but maybe during our practice we might be able to see a few. This is the Iowa brace, which you can see the same way. We have the three straps over here, a bit of hint of AFO if you can make out from there, a little bit of structural design which has been taken from AFO. This is again almost same as a DB splint or Steenbeck brace, but here normally the corrected foot is kept at almost 60 degrees, whereas the neutral or the normal foot is kept at 30 degrees. That is the only difference from the normal DB splint as well as the Steenbeck that we use. Mitchell brace or the Ponseti brace, the most popular brace in the world. So this is a brace which we commonly use, or which was actually almost the same design which Dr. Ponseti used after his corrections and that. Again, a similar kind of design. The principle remains the same in this case. Whereas in this case, there are a lot of people who have shifted over to the Mitchell brace from the other braces and from this brace, which is the Markle brace. Now, the only problem with this brace was it was heavier. It was more cumbersome to put by the parents. So gradually, most of the people in the developed countries have shifted from the Markle brace to the Mitchell brace. This is another newer design, you can say, and old wine in a new bottle, if we can put it in that way. The only difference I found, because I had the luck of, this thing going through this design during my last CTEV conference. So basically, they have a plastic abduction bar in the design, which they have incorporated. The basic design remains the same as the DB splint. And this is a work of American institute, which they have put in the through charity work, and they have different type of braces. The only good thing I noticed about this brace was the ease of removal of the abduction bar for the shoes, and the shoes can directly be used as an ambulatory shoe as well. So this is the advantage which I noted over the other braces when we were like the Miracle Foot. It has not yet been not become very popular in India as such, but we'll see about it. Now this is another modification which we have come up in the recent years. I have still not used it in my practice, haven't been able to use it. This is the Dobbs adjustable bar for the club foot. Now, normally the most common reason for non-compliance of the brace was that roughly we used to have the parents will come and tell us that the children are removing the brace. They are not able to move both the feet. The parents used to remove because they are not able, the child will become irritable. They will remove the brace. So this brace actually ensures that the child is able to move both the foot independently, and he can crawl, he can play, he can do most of the things with this adjustable bar. So in this case, another issue which was addressed, or which was another shortcoming of our other braces, which I have mentioned before, is that in this case, the calf size, or the calf atrophy, which we commonly saw after application of the cast and the brace. So this issue can be supposedly mitigated with this. So it is available in India right now. And I hope that whatever advantages I've just mentioned, it is actually mitigating that calf weakness and the other problems which we have been facing, because parents normally come back to us repeatedly with a lot of complaints that why the calf of the treated side or both the sides is thinner than the other side. And they normally take it as a issue for delay in walking and other things. This is another innovation. This is just a modification to the existing braces. This is an electronic monitoring or a digital monitoring which has been introduced into the calf, or into the shoes which we are using. This records the data that how the compliance, or how much time the foot is actually inside the shoe. It collects the data digitally and records it. It can be used as a tool for patient compliance, as well as it is a way for, or you can say it's a technique for knowing the foot dynamics after it has been treated. Again, has just been introduced few years back, I suppose. This is known as the Padma Pada. It was developed here in India only, and we are still looking forward to the results of this, and how we are able to incorporate the results, what new information we can get about the CTEV. Now, future guiding lights. The article which I came through recently was an Indian article in which a comparison of the DB splint and Steenbeek was done, and they yielded absolutely equal results, and just the advantage that Steenbeek is cheaper and DB splint is more comfortable. So that's the thing. So nowadays, when we have seen so many braces over here, the brace development will be largely guided by the weight of the brace, by what we have been hearing from the parents, ease of removal of the bar, and maybe the issue that the parents will want to use the same shoe which they have been using with the DB splint, and the compliance of the child. So maybe when we get real-time data, use of apps, we might be able to develop braces which will be far more patient-friendly as well as parent-friendly. Now, there is an indication for using unilateral braces in case of poor compliance as well as early recurrence. It is not like that we have to use the appliances which have been mentioned over here. We can use the AFO braces, we can use the Ponseti AFO braces as well as the braces which have been showed with the measure. But again, the results are really not very good with this braces when we use it on a unilateral and especially in a non-walking child. Now, as mentioned, in case of syndromic and other issues, what I normally follow is I do a monthly review of them with my orthotist with me, and I'm there. Additional cushioning or modifications of the fat puffy foot most of the time is done for syndromes like arthrogyposis. And parents are repeatedly counseled and they are asked to demonstrate the bracing and the exercising techniques in the clinic in front of me. So this is how I try to, in case of poor compliance or when I'm seeing that it's going for an early recurrence, then normally I try to follow these things to prevent the complications from happening. Now, relapse is defined as any deformity which occurs after commencement of the brace. And early relapse would be any recurrence within 2 years of commencements of the brace. So this is a definition which is followed by most of the people over here. Various literature have put it at 1 year as well as at 6 months after the initiation of the brace. But normally at 2 years, most of the time, the relapse, if it happens, it will be visible to us. Now, the red flag when we are talking about recurrence and relapse, most of the time it's the atypical foot, which is the culprit. So we have to look for these signs, which have already been mentioned in detail. We have to look for the volar crease, the small bean-shaped foot, shortened big toe, as mentioned before, stiff foot. And pointing out that the female sex was more prone to recurrence. There has been only 1 or 2 studies which have actually mentioned that females have more chance of recurrence after or more resistant form of that. But these are just 2 papers which are there. And age at initiation of treatment. I will not go into the detail of this. We have already had a discussion, an extensive discussion on this. According to me, definitely age at initiation of treatment is a factor. The later we start, I think more the chance of recurrence or more the chance of improperty. This is my personal view from my own experience till date. Now, causes of relapse, again, there is a brace. We have brace non-compliance, which has been told. Lack of parent education. One of the studies by Goldstein in 2004 has specifically connected that parents who have not been to school, so they have a 10 times more incidence of recurrence. So this is the second most important factor of the cause of relapse or recurrence, you can say. And functional brace issues which need to be addressed with the orthotist. Castist issues, this is totally in casting issues which are totally in our hand, like improper technique or the improper manipulation of the tarso-metatarsal joints, and poor patient tolerance. The patient, like what we normally see, the child is not wearing the brace properly. Now, signs of relapse, I've tried to shorten them into 4 points over here. Callosity formation at the point of pressure or whether shoe wearing, a red flag sign for relapse. Return of the various components of deformity, cavus, adductus, varus, and equinus. The Pirani score deteriorates. Now, this is again a point of discussion or controversy because a lot of the relapse cases have flexible deformity and the Pirani score might not be as bad as we would have expected. So this is again a point which is up for discussion or is controversial. Dynamic supination while walking, yes, most of the cases which I see of relapse, they normally have a dynamic supination, and it is an early sign for me to note that we need to go for some corrective recasting or thing. This is a classification. I have again simplified it. So here normally what we are seeing is the classification that we are seeing is first what are the deformities that we see. Decrease in ankle dorsiflexion from 15 to neutral after the treatment had achieved a normal dorsiflexion. 1B 4-foot adduction has again come up. 2A, we have fixed equinus of any degree. 2B, fixed adduction, and 3 is 2 or more deformity. So this is something which is very generalized, and just to so that we can have a normal discussion on this. A high initial Pirani score should again serve as a red flag that the chances of relapse is very high. And recurrent heel virus with loss of dorsiflexion is again a very early sign that we normally see in case of relapse. And as mentioned, I just put this point here to make it more prominent. The parental educational level, as Dobbs et al. Had mentioned in 2004, that this normally has a high chance. So we have to keep talking with the parents, as well as we have to ensure that how educated they are. Now, what to do? Not going into the much details as mentioned, we have to recast. We have to repeat the tenotomy, as mentioned by Ritesh sir before me also, that the tenotomy, sometimes we have a broad tendon that needs to be tenotomized properly. This is the commonest fallacy or mistake that we make, that tenotomy is not proper. That's why the equinus deformity maybe it recurs. And this early treatments or early treatment of the recurrence, they normally prevent any major surgery from happening in the past. My treatment plan would be to get a Pirani score, start casting at the earliest in accordance with the principle of Ponseti. Tenotomy as and when needed. We normally try to, I try to be a bit more liberal about it, because I normally perform tenotomy in most of my cases. And in future, to prevent recurrences, we might have to, we will have the, I hope we will be having the apps for compliance along with the digital data that we have, and maybe digitally monitored orthoses like the Padmapada. And this is one of the ideas which I have tried to inculcate in the place where I practice, is CTV parents group sessions and educative programs. I feel that when we are surrounded by people who are who have the same problem, like their child has the same problem, and that, so they can actually share ideas as well as give us a lot of ideas about how to ensure the proper compliance of the brace so that we can prevent recurrence, as well as they can educate each other also, rather than one-to-one session that we normally have with them and that. So this is all I wanted to tell about the recurrences as well as the braces that we have used. So it is crooked, but it is definitely correctable. So we should just try to put our best foot forward and try to get the best foot for the child. Thank you, sir.
Thank you, Abhishek. Very nice lecture. And now we have our last speaker, Dr. Abhishek Nandi, for common operative intervention in the CTEV. This is our last lecture. Abhishek, are you ready?
Yes, I am ready. So before I start with my surgical thing, I'll just like to share something on Padmapada. So this Padmapada was introduced by Dr. Risha and in association with the Indian Institute of Science, this Bangalore, and it is patented with both Dr. Risha and IISC. With CMC and ISC collaboration. So we generally use this Padmapada. We generally don't give the DB splint. We use this dynamic splint. There are patients who don't consent for this study, where we remove that sensor. So that sensor and that hole in the heel, those are the two important part. It has got three sensors, the three tripods of the foot. One at the heel, one at our great toe, ball of great toe, and one at the little toe. So if the foot is falling on that sensor, it will have a peak graph. So that chip which was having that we see in our laptop, and we draw the graph, and we are able to see at which point of time throughout the day the child is wearing the shoe. So as we all know that the cause of relapse is non-compliance. The most common cause is non-compliance. We have got a group which work on these patients and patient education, and we have been able to at least decrease the relapse, if not completely eliminate it, by the use of this Padmapada. Now, ma'am is trying to commercialize this Padmapada. She has spoken with Tainor, I think, and soon I think it will be open in Indian market, maybe in 1 year or 2 years. So that is the latest on Padmapada.
Thank you, Abhishek, for updating.
Abhishek, can I just interrupt before you start? Yeah. What information I got, I have seen only one demonstration of this. I have not been like, I've seen only one demonstration of Padmapada. So this is a real-time data, or like 1 hourly the chip detects the data and that over
So it is a continuous data. So when we put that thing into our software, so throughout the day we have got is a continuous variable curve.
Okay.
So whenever the child is not wearing the shoe, it will show a sharp fall. Generally, we use a left as red and blue as left for red and blue for right. So accordingly, if it is a blue curve which is coming, it is the right foot, and the left curve which is coming, it is the red foot. So this is how we proceed. So shall I share
Okay,
it?
share your screen. Yes.
It visible, sir?
Yes.
Yeah.
So my second topic of the description this evening. Sorry for my lack of connection in the first topic. I have taken some slides from there in this also, so I don't think it will be a great miss. So common operative intervention in CT, it is a quite extensive topic which was given to me by Akhilesh Da. So I have got literature, some lines from Bradford in 1889. The literature on the treatment of club feet is, as a general rule, that of unvarying success. Yet in practice, there is no lack of half cured or relapse cases. Sufficient evidence that method of cure are not universally understood. This is even true for today also. So I have got a case, a 5-month old child who presented to us with CTEV. We have done Ponsity casting, and there is a persistent equinus. So the commonest surgery which we perform in CTEV is a tenotomy. So this is a percutaneous tenotomy, and we have got the dorsiflexion. So similar case, a 7-month-old child. Now, what will be the plan of action for this? I must ask my teachers to comment. So can I start with NK Das, sir? So what should be what will be your plan, sir?
Is audible?
Hello, am I audible?
I think sir is offline.
Okay. So Akhilesh, why can't you tell us what will be your plan on this foot? What is your diagnosis first? You have told a lot of about this short great toe and hyperextended great toe.
Most probably resistance club foot.
Yeah, that is correct. And anything else you want to add, this Akhilesh da? So this is what looks like a complex club foot, to be exact. It has got a rigid equinus. It has got a short great toe. It has got an extension of the great toe also. So tear tenotomy might not suffice, though it looks like. So what we will do a posteromedial release. So when we start with our discussion of posteromedial release, as Sir has already told that choice of the incision varies. So it is surgeon's preference. So Turco has given this incision, which we say as a Turco's incision in 1970. So the principle which he used was correcting the deformity of the calcaneus beneath the talus. So he was addressing it not in the talus, but beneath the talus. And he did a complete subtalar release of calcaneofibular ligament, and release of the introitious talocalcaneal ligament. You must have seen that today, in today's world, we generally avoid releasing the introitious talocalcaneal ligament. But he told that in his study, he advocated introitious talocalcaneal ligament release. So when he released the introitious talocalcaneal ligament, he was able to evert the calcaneum and rotate it. So this was the Turco's incision. It was a curvilinear incision on the medial side, just behind the medial malleolus. Most of us use this incision. Then we identify the tibialis posterior, the flexor hallucis longus, the flexor digitorum longus, the neurovascular bundle. One thing I just want to highlight is the Achilles tendon is easily palpated and seen from this incision. So we can do Achilles tendon tenotomy through this incision. So this is the Henry's knot. Now Henry's knot is one of the crucial structure which has to be released so that the flexor hallucis and flexor digitorum longus is fully released. So the posterior capsule consists of the ankle, that is the tibio-talar capsule, the subtalar, as well as we release the deltoid ligament. Now I have to tell that the superficial part of the deltoid ligament is released, not the deep part. That is the one structure which all the posterior medial release people have advocated not to release. And the talofibular ligament, these are all released. The superficial deltoid consists of two parts, the tibiocalcaneal and the tibionavicular. Both are released, as well as the spring ligament. Now, I just want to say the reduction of the talonavicular joint was maintained by a K-wire. Now, this K-wire is a controversial. Many people say we will apply it. Many people don't apply it. We generally don't apply in our center, but there are people who uses the K-wire for talonavicular reduction. Next is the Carroll. Now in Carroll, he for his correction, talus was the fulcrum. He externally rotated the talus inside the ankle joint, and he uses the two incision technique, a normal curvilinear medial incision and a posterior lateral incision. The medial incision was like similar to Turco, but smaller in size. The posterior incision was extended along the lateral border of the TA. This is a two incision technique. More or less the structure which are released are same, but only if it is two incision, that is single incision. One more thing I just want to highlight. This is the first time where he told that abductor hallucis can also be released. Now Goldner, he also internally rotated the talus in the ankle joint, but he did not release the subtalar joint. So in his study, there was more of undercorrection. So the undercorrection was because of the internal foot progression angle was there, and rarely there was a valgus overconnection. Now Mackay. Now Mackay did not touch the talonavicular joint, but his principle was to maintain the ankle mortise. So he used a transverse Cincinnati incision and he did an extensive release. So the Cincinnati incision, as previously told, has got advantage that it is easy. All the structures are easy to access, and since it is prone position, it was anesthetically problem. But for surgeon, the foot was easily movable, and the cosmesis is good. Disadvantage is again it is the tension on the suture line while attempting to dorsiflex the foot, and it is difficult dissecting high enough for lengthening. So in Mackay, we generally release the posterior tibial Achilles tendon. Now the important thing here is the sheath of flexor hallucis and flexor digitorum were dissected free but not open. This is one thing which we do. We generally, this is one of the modifications which we have done, that the sheath of flexor hallucis and digitorum, we generally release it for older child. But if it is a younger child, the sheath is not visible, so we have to do a formal Z lengthening. The talonavicular and calcaneal cuvette joint capsules were also released, and the talocalcaneal release was done, but only in medial and posterior. This was a difference in Mackay. So Mackay again has used two K wires. So this, according to him, was most important factor which maintained the reduction for his surgery. Simmons did a complete subtalar release, but with a posteromedial incision. So he released the lateral part of talonavicular joint, lateral part of subtalar joint, the calcaneofibular ligament, the introitious calcaneal ligament. Now for his principles and Mackay principles were same, only the incision changed. So there is some difference between the Mackay and the Simmons. The Mackay medial and posterior part of the introitious talocalcaneal ligament was released, but in Simmons he released complete talocalcaneal ligament. Because Mackay did an extensive release to interop, radiographs were not required, but Simmons regularly used radiograph for checking the reduction. Now FHN and FDL. This is the important thing where Mackay advocated that only sheath to release, but Simmons incised the entire sheath. Plantar release was routinely done in Mackay, but it was done only for severe cases in Simmons. The prominent medial portion of the naviculectomy was also added in Mackay, which was not added in Simmons. The most popular now is the a la carte procedure, which we follow in our day-to-day practice and which we have moved. So it is a one-stage medial and posterior release and T2 reduction of CTEV, midfoot at talonavicular joint. And with medial reincision, we are advocating to release the abductor hallucis if necessary. Medial capsulotomy of the talonavicular joint, posterior talar joint, heel cord lengthening, posterior talar subtalar joint. And here one important thing, the posterior part of the subtalar joint should not be opened. This is one of the things which was advocated by Ben Sahel. So the soft tissue procedure should not be extensive. So because of the risk of overcorrection. So if it is a isolated equinus deformity, where in an older child or some complex CTEV, so T8 anatomy might not suffice. So we have to do a lengthening or a posterior capsulotomy. So intrap assessment, heel varus, all has to be heel varus and internal rotation is taken care of by posterior release. So again, the timing of procedure I don't want to go in. Some say it should be done before around 1 year of age because the structural larger anatomy is better and repair is better. Some say we have to do it early because the cartilage remodeling is better. The disadvantage is again if we do, since we release at early age, this will lead to recurrent fibrosis. But Simmons has given us given a data that roughly if the foot size is around 8 centimeters long, you can go ahead with a soft tissue release. So the same patient which I showed was that we have done a la carte. We have done a posteromedial incision. We have identified the master knot of Henry. We have released the FHL, FDL. This is the master knot of Henry, which is shown. So what are the post-operative complications for PMSTR? So first is the loss of correction. This is the inadequate post-operative position. Generally what happens that when we cast, there will be a lot of swelling. So within first 3 or 4 post-operative weeks, the swelling will come down and cast will become loose and there will be a relapse. So it is very important to repeatedly see the patient for at least 3 weeks, because if you have to change cast, it is effective only in first 4 weeks. After 4 weeks, it is ineffective. So there is a dorsal subluxation of the navicular. Now what causes it is the tight tibialis anterior. So when we or inadequate release of the plantar fascia. So this will lead to a dorsal wedge, the wedge shaped navicular, and there will be a subluxation. So if it is asymptomatic, we need not to do anything. Just manage it conservative, maybe some medial arch support. If there is mild pain, we will again do observation. But if it is a symptomatic, so the procedure which is advocated for a talonavicular subluxation is the third street procedure. So it is a circumferential capsulotomy of the talonavicular joint. So the 3 streets are the navicular cuboid, the lateral cuneiform and the cuboid joint, proximal end of the 3rd and the 4th metatarsal. What it does is the medial column and the lateral column both are separated and it is reduced, the navicular is reduced and the KY is reduced. So Q and Janssen, they have advocated a complete mid-tarsal release plus a plantar fasciotomy. In older child, we can resect the navicle by doing a naviculectomy, and we can do orthodesis also. So what is valgus overcorrection? So as Sir was saying that translational versus rotational. So some mechanism is there. So if we do extensive lateral translation, there will be in translation, there will be excessive lateral translation of the calcaneus over the talus. But in rotational, there will be a rotation. So if the talocalcaneal ligament is cut, it has been shown that calcaneofibular ligament is thickened in CTEV. So this calcaneofibular ligament becomes the new axis of the rotation and it will pull the calcaneum towards it. So it will produce a translation kind of a motion. But if the talocalcaneal ligament is preserved, it will form a rotational kind of mechanics and will form a rotational deformity. So where translational deformity happens is the Simmons subtalar release, where there is a complete subtalar release, including a talocalcaneal introitious ligament, or a Turco, where the calcaneofibular ligament is not released. So both will present with severe valgus in hindfoot. So what is the difference is the thigh foot angle. In translational, the thigh foot angle will be neutral, but in rotation, it will be a positive thigh foot angle. And also the tendoachilles. In translational type, the tendoachilles will be sometimes contracted, but the tendoachilles will be usually contracted in this rotational variety, and this rotational variety will be presenting more like a idiopathic flat foot. So again, radiology. Now radiology is the talonavicular joint alignment is the most important things which we will see in radiology. There will be a sag in case of rotational, but there will be no sag in case of translational. So what is the management of translational and rotational? In translational, we'll do a custom molded orthotics, some posterior calcaneal medial displacement or slide osteotomy, which was popularized by Kutsogians, but it will produce secondary deformity because the osteotomy is not at the cora. Now in rotational type, we are advocating Mosca's yellow. There will be a, if it is associated with equinus, we'll do a lengthening of the tendo Achilles. Now, for this rotational variety, this Kwan and Smith et al., there was a debate between Mubarak's triple C, which was extra-articular kind of correction, versus Mosca's calcaneal lengthening, which is an intra-articular correction. Though my previous slide, which was taken from our Lovell and Winter, which advocated Mosca, who told that this extra-articular Mubarak's triple C, which will be a medial column shortening, lateral column lengthening, and medial translation of the calcaneus, that shows a better result because here the subtalar joint is very stiff and Mosca cielo was not a good choice. Last resort for anything is a triple orthodesis. Most important thing was ankle valgus, which we need to evaluate. If it is there, we can put a medial malleolar screw or a angular osteotomy. Next complication will be a dorsal bunion, which we also say hallux flexus. The reason for this is again, once the tendo Achilles is lengthened and there is a hyperactivity of the tibialis anterior, the flexor hallosis. The flexor hallosis will be contracting to produce a compensatory plantar flexion. And hence there will be a dorsal bunion. And if it is there, the management is a reverse Jones technique, where we take the FHL and we will do a tunnel through the metatarsal neck and we will suture it. So revision, following a soft tissue release. So there are two kinds of recurrence which are described. One is a pseudo, one is a true. Now, pseudo recurrence is something like there was a persistent of deformity where it was not corrected fully in the first place. And true was a non-idiopathic cause such as neurological, where it is occult spinal dysraphism. So generally the recurrence was around found to be 10%. So in isolated equinus, where there is an increased equinus, there will be absence of heel strike. And there will be calluses forming in the metatarsal head, which causes metatarsal tear. So there will be excessive compensatory dorsiflexion across the midfoot joint. So what is the management? Is the Achilles tendon lengthening with or without posterior capsule. Equinus in the older children with clubfoot after one age can be successfully treated with Achilles tenotomy and Ponseti casting. This is one paper which has advocated Achilles tenotomy after 1 year. So it was given by Spiegel DA. The heel varus, the residual heel varus of less than 10 degrees are well tolerated, but occasionally the heel pad is mobile, and so a true bony varus should be evaluated first. So the Droyer's closing wedge osteotomy is usually preferred. Lateral closing wedge osteotomy is preferred over the medial opening wedge because of the wound complication. Cavus. The cavus has to be evaluated if it is associated with first metatarsal drop or all metatarsal drop. Cause of cavus are generally at right plantar fascia, overactive tibialis anterior, which causes a dorsal may cause a dorsal subluxation of the navicular, as I explained before. So cavus, if it is there isolated without any ray drop, just do a plantar fascia release. If it is the first ray drop, if the age is above 4 years or 8 years, do a first uniform dorsal closing wedge osteotomy. Above 6 years, first uniform open wedge osteotomy and iliac bone graft. With closed, if the metatarsal physis is closed, we can do a oblique osteotomy. If all rays are in flexion, we have to do a midfoot osteotomy. This is the difference. First ray drop, only do a first ray osteotomy. All ray drop, we have to do a midfoot osteotomy. So this is a video of the next recurrence. This is a child around 3 years of age, which was corrected by Ponseti. We have done Achilles tendon. The child was in bracing for around 2 or 3 years. And he presented to us with a dynamic supination deformity. So supination deformity, whether it is dynamic or static. Now dynamic supination, most common deformity. Now it is again a controversy. Some say it is a equinus, which is most common, but there are literature which shows equinus is not more common. It is just the pseudo recurrence which we take into account. So dynamic supination was the most common deformity seen after conservative or surgical management, mainly in swing phase and the weight will be on the lateral aspect of the foot. So this is how this picture was taken from Professor Benjamin's article, where we are seeing the axis of the subtalar joint and the ankle. We are seeing the EHL, EDL, and the tibialis anterior. They are all dorsiflexors. We are seeing the tibialis posterior, peronia, and Achilles, which are all the plantarflexions. In subtalar joint, we are seeing the tibialis anterior and tibialis posterior, which are the inverters, and the peronia and EDL, which are the everters. So if it is overactive tibialis anterior, it generally causes a dynamic supination deformity. So if tibialis anterior are strong and peronia are weak, there will be compensatory FHL involvement, as I told before, which may cause a plantar flexion in first ray. Overactive tibialis anterior and weak peronia can directly cause a dynamic supination of deformity. Persistence of this dynamic supination over a period of time can cause a rigid supination of the forefoot, which is a static deformity. It will have a metatarsal adduction, and in hindfoot it will be having a inversion. So recurrence occur between 10 months to 7 years. That is roughly the age which was given in Level and Winter, which when I went through the literature. So what are the treatment? So whatever is the recurrence will start with Ponseti first. If it is less than 1 year, we can do a tenotomy, or if it is more than 1 year, we have to do a formal lengthening, and we'll put in a foot abduction splint. Choice of splint, again, it is varied. If it is above 2.5, we can add a transfer. Now, whether to split and transfer, whether to do a complete transfer, that is again a controversy. In our center, we generally reserve the split transfer to the cerebral palsy patient, and we do a complete transfer of the tibialis anterior to the CTEV patients. So tibia lateralization, we generally transfer to the lateral cuneiform. Generally, cuboid or fifth metatarsal should be avoided because it may cause excessive eversion. So this is the picture taken from Lull and Winter. So it is showing a 2-incision technique. We can use a third incision in the distal part of the tibia, where we can take out the tendon and we can reroute it through it. But generally, we also use 2-incision technique in our center. So here we are rerouting the tibialis anterior on the third cuneiform. So residual midfoot abduction and static supination. Generally, this is what is also known as a bean-shaped foot. If it is less than 2 years, we'll again repeat the subtalar release. We'll again repeat the complete soft tissue release. If it is between 2 to 4 years, generally osteotomies are not recommended. If we have to do, we can do a cuboid enucleation, but has to be done along with the medial soft tissue release. Above 4 years, if it is excision of the distal part of the calcaneum can be done, which is known as Lich-Blau. Calcaneum cuboid fusion is Evans and opening. This is the pictorial view. First is the Evans technique, where we generally do is after 4, because before 4 bones will be generally cartilage and it will not fuse. So it is a calcaneum cuboid excision and fusion. Second is the Lich-Blau procedure, which is done, which can be done after 2 years of age. Now the thing is, here we produce a pseudo-arthrosis. Third is this reverse of the calcaneal lengthening osteotomy. So here we are in calcaneal lengthening osteotomy, we do a lateral column lengthening. Here we are doing a medial column shortening. Sorry, in calcaneal lengthening, we do a lateral column lengthening. In this one, we do a calcaneum, the medial column shortening, medial column lengthening. And the last one is a Goldner's procedure, where we are doing a medial closing wedge osteotomy. Sorry, we are doing a lateral closing wedge osteotomy of the cuboid. Now, A, B, and C, the difference of A, B, and C with the D is, if you can see the navicle. The navicle, the talonavicular joint can be reduced with A, B, and C. But with the procedures D, we cannot reduce the talonavicular joint. So the D should be reserved for those cases where there is no talonavicular subluxation, or it should be done for the metatarsal adductus, not for the supination deformity. So there is a combined Fowler's procedure where we can shorten the lateral column and we can lengthen the medial column. And we can do a double talar osteotomy. This I will take later. Ilizarov can also be used for soft tissue distractions. So it was popularized by Grill, and Hutchinson et al. Also documented the benefit of Ilizarov management using pedobarography. We used extensive Ilizarov in our CMC days, but because it caused a lot of so we have stopped using Ilizarov.
Abhishek, you have to conclude because we are oversetting half an hour.
So I'll come to some cases. Some 2-3 cases are there. So this is a case with a 2-month-old female, which having a complex club foot. This is one of Dr. Bala's case. So what is the what will the plan of management? So this was a 2-month-old female which presented with a complex club foot, and we have done a multiple small tenotomies, and we have made the foot plantigrade. So this is a midfoot break, which presented to us after Ponseti correction. This is a newborn which is again presented to us with the complex clubfoot. And this is a 11-year-old child with bilateral CTEV, and we have done multiple procedures. And when he came, there was the scores, the midfoot scores where the total Pirani score was around 5. So the procedure which we did was a talar osteotomy, and this was the result. So this is the osteotomy which we now do for cases which required Ilizarov. So this is in just what are the different procedures which we can do. So if it is a newborn, we can do a Ponseti followed with tenotomy. I want to highlight the relapse part. If there is a persistent forefoot and hindfoot deformity, and the body and the dome-shaped body of the talus, we can use Ilizarov. If it is a flat top, we can do gradual correction. Again, if it is a persistent forefoot and hindfoot deformity, flat top talus, age is more than 10 years, we can do a triple orthodesis or a gradual correction. So thank you.
Thank you, Abhishek. Very complex topic, but you have elaborated very well.
Actually, I know it was quite extensive because the topic which you gave me was surgery.
Yeah, I know, very difficult to conclude, but you have managed it nicely. Rajiv, your comment, and then Chinmay sir.
I think Chinmay sir, I think it is an excellent webinar, and thanks to our national faculty Ajay Singh and Dr. Ritesh Renu, and our regional faculty Akhilesh, Kumar, Abhishek Nandi, Abhishek Shah, and over to you, Chinmay sir.
Sir, your concluding comment. Unmute, sir.
Unmute yourself, sir.
Sorry.
Yes, sir.
And then vote of thanks from, yeah.
No, sir, again you have muted.
Sir, please unmute yourself.
Single click.
Single click, otherwise it will again get muted. Yes, sir.
Yeah. So, first of all, thanks to the national faculty, Dr. Ajay Singh and Dr. Runu, to be here with us, and we have explained the subject very nicely. And to sum up this CTEV subject, the guideline is whatever the situation, whether complex or syndromic or simple CTEV, one should start with the plaster. And whether we should start very early or within 1 month, that is controversial because the skin is very tender. So in the early stage, if you start with the plaster, there will be ulceration. And we have seen lots of cases with skin ulceration after plaster, then we have to stop the plaster procedure. And usually after 3 to 4, if the satisfactory, you need to go for tenotomy and best. If it is not satisfactory within 3 to 4 weeks, then we should think of the operative procedure in the form of posteromedial release. There are lots of operations, but usually the posteromedial release is the best option. From posterior release in the form of lengthening of the tibial lengthening of the tendinoid, and capsulotomy of the ankle joint and subtalar joint with lateral release of the lateral ligament, and medially it is the release of the shallow navicular capsule and navicular puniform capsule, and division of the head is not. Head is not is nothing but the condensation of the deep fossa over the crossing of the flexor digital longus and flexor horizontal longus. This is a very tight knot. And sometimes the tendons, these bigger tendons may be divided or lengthened, and this is we have to maintain the plaster. Usually, most of the cases, almost 99% of the cases can be managed in this situation. And even in the syndromic case, initially we start with the plaster that will soften the tissues and operation will be relatively easier. And regarding the follow-up, that heavy and complicated cases, usually the decision will not occur. It is more easier because for a long time, dense bronze screen is used for a long time, and that is enough and of low cost. And usually, most of the cases with this base, it is sufficient. Only thing is, we have to follow up the patient at least up to 3 to 4 years because after that there is a chance of recurrence, and the guideline is whether the baby can run or not. When the baby can run, the muscles are well balanced and chance of recurrence are usually very rare. So this thing for a common orthopedic surgeon, unless they are the pediatric orthopedic surgeon, this is enough for benefit of the CTEV. And with this comments, I conclude my talk. Thank you. Thank you all again.
Thank you, sir. Let's conclude the meeting. And thank you, Ajay Singh, sir. Thank you, Nitesh, for joining. And
thank you, everybody. Thank you. Bye-bye.
Stay safe, stay well. Good night.
Thanks, sir, for responding on
Thank you, Kiranda. Thank you, Sandeep, sir.